Good afternoon, everyone, and welcome to the fall edition of the Behind the Scenes lecture series. My name is Shauna Seabrook, and I have the great honor of leading the Peter Mott Cardiac Centre campaign at the Toronto General and Western Hospital Foundation. I want to start by thanking all of you for being here today. We are so grateful that you took the time to join us virtually for this lecture. You may have previously attended one of our question and answer live streams on COVID-19, or perhaps maybe the behind the scenes lecture that features scientists from the Donald K. Johnson Eye Institute. Through these lectures, we're committed to sharing with you how we are accelerating research to improve patient outcomes in Ontario and around the world. By taking you behind the scenes, we want to show you the impact of your generous support. As many of you may know, the Toronto General Hospital was ranked for the second year in a row as a top 10 hospital in the world by Newsweek. This year, moving to number 4th spot and the only Canadian hospital to be ranked in the top 10. Each of you can feel as proud as we do that your support has enabled us to achieve this prestigious award. Today, I have the privilege of introducing two remarkable individuals who care for patients with some of the most complex cases of heart disease in the world. Their vision and relentless drive has led to advancements that I'm sure you will find inspiring. Before we begin, just a quick reminder, we'll be taking your questions at the end of the presentation. So follow the Slido link in your confirmation email for details to go to slido.com and type in the hashtag BTS to submit a new question or to vote for the one that you're most interested in hearing the answer. And now to introducing our guest speakers. Dr. Heather Ross has many titles. She's the head of the Division of Cardiology at the Peter Mott Cardiac Centre and the site lead for the Ted Rogers Centre for Heart Research, just to name a few. 26 years ago, when she began her career at the Peter Mott Cardiac Centre as a heart failure specialist, she was the only person in the heart failure program at that time, and remembers questioning whether there would be enough patients to see, and was it where she could make the greatest impact? Well, as she's managed to build the heart failure program to the largest of its kind in Canada, I think she has her answer. When you meet Dr. Ross, it's impossible not to be inspired by her all-in, all-time attitude and her utter devotion to improving the quality of life for patients with heart disease. Today, she is transforming the future of heart failure management to use personal medicine strategies to ensure the right patient is treated at the right time and in the right way. Last year, Dr. Ross was the recipient of the Canadian Heart Failure Society's 2019 Annual Achievement Award, and last month was honored as the inaugural recipient of the Women in Cardiovascular Science Mentorship Award from the Canadian Cardiovascular Society. For those who have had the privilege of working with Dr. Ross, this will come as no surprise. One of those mentees is Dr. Yaz Moyetti. Dr. Moyetti is a heart failure cardiologist and one of the newest recruits to the Peter Mott Cardiac Centre. She officially joined the team as a clinical associate in September 2020. However, she began her career at the Peter Mott Cardiac Centre in 2015 as a heart failure program fellow, and furthered her training in digital health and precision medicine at Stanford before returning to Toronto to officially join the team. Dr. Moyetti brings wonderful energy to the Peter Mott Cardiac Centre and shares, as so many of them do, that all-in, all-the-time commitment to patients with heart disease, and provides a strategic lens for how to use digital health to eliminate barriers that some patients face in accessing care. While looking after her newborn son in April of 2020, she led the team who built a COVID-19 virtual clinic in a matter of weeks, which you'll hear more about today. I'm thrilled that both of these visionaries could join us today, and at this point, I'd like to turn it over to Dr. Ross to begin this presentation. Welcome, Dr. Ross and Dr. Moyetti.
Thanks, Sean. I really appreciate the kind words. It's a real honor to be able to present today some of what we've done, some of where we've been, and some of where we're going, which is hopefully to really new places. And it's talent like Yaz that's going to get us there. I'm very proud of the program. So I wanted to take you on a little journey towards a new model of virtual healthcare, or what we call touchless cardiac care at the Peter Mott Cardiac Centre. And I'm going to give you a bit of an idea of, as I said, of where we've been and where we're going. So let's talk about heart failure. What is heart failure? Heart failure is the inability of the heart to pump adequately to meet the needs of the body. It is a growing condition. There are about 1 million Canadians who have heart failure, and it's a dramatically impactful condition for patients. So, in the first year after diagnosis, the average patient spends almost 1 month in hospital, away from loved ones, away from family, away from job. And the cost to that individual is enormous. The cost of the healthcare system is also enormous at somewhere between $2 and $3 billion a year in Canada alone. Despite a lot of advances, the outcome for heart failure remains a real challenge, with an average life expectancy of 2.1 years after the diagnosis. And for those of us who are willing to admit that we're not still 29, the average likelihood of getting heart failure is 1 in 5. So 1 in 5 for those of us over the age of 40. When someone gets diagnosed with heart failure, there's this very early phase, or what we call a transition or vulnerable phase, immediately after the diagnosis. And then most patients end up in a plateau. But the risk of hospitalization after that initial phase is very high. So 1/4 of people will end up back in hospital 30 days after the diagnosis has been made. And almost 50% will end up back in hospital within 1 year. And what does that mean if you're a patient? Well, it's bad. So this is a scary slide from my perspective, and it shows the actual survival by hospital admission. So by the time you've had your 4th hospital stay, your likely survival is about 6 or 7 months. So the risk of dying increases after every heart failure admission. So we can look at this as terrifying, or we can look at this as an opportunity. So how do we actually keep patients out of hospital? How do we keep patients safe? And how do we engage patients in their own care behavior? So how do we improve patient self-care behavior to try to, between our side of what we're doing with the medications and the advice and what the patient is doing, to help keep that patient out of hospital? So this takes me back to when I first started, and we had this approach of recognizing that one of the commonest reasons that a heart failure patient ends up back in hospital is actually because they're retaining fluid. So either through too much salt in the diet or not quite the right medication doses, they end up retaining fluid. And when they retain fluid, that builds up into the lungs. It causes shortness of breath, fullness in the belly, swelling in the ankles, tremendous fatigue. And so back in 1998, we wanted to try to make sure that patients stayed at what we would call a goal or target weight. And so what I used to do is give them this piece of paper and have them tape it to their fridge exactly like this. And I would say, Mr. Smith, when you get up in the morning, after you've peed, buck naked, get on the scale, remember that number, put on a robe, go to the fridge, look where your weight is on the chart, and go along that row and take whatever it says you should take in terms of your water pill. And this was what we termed a Lasik sliding scale, and it was one of the early ways that we tried to keep patients in range. So we started thinking about this, and it was like, okay, this is kind of, low tech. What else could we do? And we remembered, hey, there's this thing, it's called the internet. So we went to this idea, which was to build the clinic online. And we started this project in 1999, and we built this secure portal for patients to log in and to tell us how they were feeling and to answer some questions. And, this did not work. The patients found this onerous. They just didn't want to come online every day and answer all these questions. And from our side, it was a tremendous amount of work to try to figure out what was going on. It took way too much time. And by 6 months, very few patients were still on it. So that was an abject failure, which is never a bad thing, right? Never a bad thing. So we started thinking again, and you have to remember that there is so much power in the phone that we recognize that now, right now in 2020, 80% of us effectively have a supercomputer in our pocket. And if we think about it, the amount of power, the amount of compute power in your phone is equivalent to what landed a man on the moon. So that is a tremendous opportunity. We also know that there's been huge penetration of phones and huge penetration of smartphones. And this is similar, this is American data. It's not actually dissimilar to our own clinic. And so we thought, and I'd love to be able to say it was my quote. It isn't, but it's my favorite quote, which is, why don't we enlist the help of the largest healthcare workforce, which is the patients? And this brings us to something that we thought about, which is called Medley. And Medley was originally designed for a medley of diseases, hence the title, but we got very focused on it as an application for heart failure. So again, we went back to that first graph that we stuck on the fridge and how we would manage patients, our abject failure of using the internet. And we thought about what the actual paradigm is or what happens in heart failure. And when we manage patients with heart failure, we see them in what we call episodes of care. So these are appointments where the patient comes in to see us or they go in to see their family doctor. And really, just by odds, it would be unexpected that the patient would be unwell at that booked episode of care. And we started thinking, most of the trouble that happens to patients actually happens in between these episodes of care. And we need to think about a different way to manage this. This is an indicator of how traditional telemonitoring or home management of heart failure happens. The patient takes their physiologic parameters, similar to what I said with the paper that we used back in 1998. They transmit it historically by phone to somebody who's sitting in a room who may not be in their circle of care. That data is reviewed, they look at trends, then they have to try to track down somebody to review that information and then make a decision about what to do, and then they have to try to get a hold of the patient. And we looked at this and we went, let's get back to our idea. And why don't we take this side, which is what takes so much time to get the feedback back to patients, and why don't we math the heck out of this? And that's what we did. So we took this side of the equation and we created a rules-based expert system, or a mathematical if this, then that type of system. And so when the patient takes their physiologic indicators in that much time, it goes through the rules-based system, it sends an alert to the patient, it sends a recommendation about therapy to the patient, and it sends the alert to whoever the most responsible clinician is, as well as the nurse coordinator. And this is the system that we built called Medley. And this is what Medley looks like. So this is a rules-based algorithm over on the right. And what's really important about this system is that it's personalized to the patient. So the thresholds for blood pressure, change in weight, or upper or lower weight is actually set by us based on what we think the target weight should be and the target parameter should be for that patient. We also have treatment plans built in so that if somebody gains too much weight in one night, which would be a signal that they're starting to retain fluid, it'll automatically push an instruction in terms of a diuretic or water pill dosage that is individualized again to that specific patient. So these are simple measurements: your weight, your blood pressure, your heart rate, and a series of symptom questions that we built into this. Because it is a clinical evidence-based advanced clinical decision support tool, we achieved Health Canada Class 2 status. And this is because, unlike every other remote monitoring or telemonitoring system, Medley does push instructions. The other really important point is that the app lives on the phone. So it's an in-app program, meaning if the patient is actually outside of cell coverage or has no Wi-Fi, they will continue to be managed every day by the algorithm. The other really critical thing about Medley, and this is where it differed from that internet failure that we had with the internet program, is because we have set the parameters to each individual patient, we can tell when a patient falls outside of the parameters. And just like in those episodes of care that we do traditionally, these are now daily episodes of care. So we're now running 7 days a week with these remote monitoring daily episodes of care. And not surprisingly, the vast majority of patients are well the vast majority of time. So 74% of people, when they enter their measurements, are actually within the range and they just get positive feedback. There is no concern. About 1/4 of the time, they get a caution alert. And this is where we've recommended perhaps a diuretic or that the measurement should be taken again. And less than 1% of the time, the alert is a critical alert or an alert that really worries us. And when we built the algorithm, we built it to be conservative because we want to make sure that we do not miss a sick patient. So there are a couple of things that come up as a flag for a critical alert. Low blood pressure with weight gain, which always worries us, or if somebody's actually fainted, as an example. Well, how did Medley work? Well, we looked at Medley in our own program. We compared our clinic, which were pretty good, to our clinic plus Medley. And what we were able to show was a significant reduction in heart failure hospitalizations, 50%, a 24% reduction in all-cause hospitalization. And when patients were hospitalized, they ended up staying in hospital for 2 days shorter, probably because we were identifying them earlier using Medley. So this is a tremendous impact for patients when you think about the data that I showed you at the very front. The other thing that we did with Medley is we said, well, patients with heart failure need to be on what we call guideline-directed medical therapy. And why does that matter? It matters because those medications improve survival and improve symptoms and improve quality of life. And yet, when we looked at registry data in the US, in the real world, only 1% of the patients in this one registry called the CHAMP registry were actually at target of what we call guideline directed, or at that time was triple therapy. And we look at that and we say, well, that's not very good. We need to do better. So we did a randomized trial comparing our clinic with Medley versus our clinic with Medley and using our nurse coordinator every 2 weeks to adjust the medications if deemed safe to do so. And what we showed was that, in fact, not surprisingly, there were fewer visits in the patients who were on Medley and having their medications adjusted by Medley. That was its purpose. But what was really important was that we showed, and that's in the middle graph, that it took less time in weeks, significantly less time, for patients to get to guideline-directed medical therapy. And when we looked out at 6 months, 90% of patients were on guideline-directed medical therapy when they had the titration. So this is an enormous impact for patients. And I want you to remember this impact when I talk a little bit about how we use this idea in COVID. You can also imagine that the cost is significantly less here because patients don't have to travel, don't have to take time off work. So it's much more efficient use of resource. And finally, we showed it was very safe to do so. So there were no significant bad outcomes in the patients in the remote titration. Well, can we do better? Everybody talks about artificial intelligence and how if you have all this data, surely we can actually do a better job in terms of figuring out how to manage patients. So we sought to do this as a Pathfinder project with Vector. And what we said was, let's look at all the data that we have on these patients. Let's look at their traditional daily measurements, and let's see if we can create Medley AI, or a system that actually does a better job of alerting. So the question was, does machine learning and a machine learning algorithm reduce the false positives without sacrificing safety? And a little bit of a teaser, we do have some really interesting information on this, which suggests that Medley AI may be able to predict the risk of an alert 2 days earlier than the standard Medley. So this may end up being quite impactful for us when we manage our patients. So where are we with Medley right now? Well, we have over 700 patients that are being looked after by 2 nurse coordinators. Is that impressive? Absolutely. If you look at traditional telemedicine, about 1 nurse to 70 patients, 50 to 70 patients. So when we think about scalability for heart failure, if I can have 1 nurse look after 300 to 350 patients safely, reduce hospitalization, improve guideline-directed care, then I'm having a tremendous impact on patients and using something that's scalable. What's really interesting about what we've been able to do with Medley is prior to the pandemic shutdown, we recognized, based on what was happening in Europe, that we were going to be in some trouble with COVID. So we moved very rapidly to remote onboarding of patients when COVID hit. And since that time, we have onboarded 367 new patients to Medley, and the vast majority of these patients were onboarded remotely, meaning that the patient never had to come to the hospital, never had to risk potential exposure in a hospital environment to COVID. At this point, we've averted more than 1,100 in-person visits by using virtual care, augmented by Medley. And outside of the trial, we've done more than 400 remote titrations of medications, again, averting those visits that patients would have had to come into to be having their medications adjusted. We're also using Medley to help enable discharge of patients who are hospitalized, and we've been able to show that we can actually shorten their length of stay using Medley so we can get them home a little earlier, and we've also reduced the likelihood that they'll come back. So that's not using it in ambulatory patients, which is the data I've shown you, but rather now using it in patients who've already been hospitalized with heart failure and were naive to Medley, and we've used Medley as a way to enable discharge. So it's been a pretty impressive growth of the program. The other important program we have is Cardiomems, and you can see that's a live shot of the device. We were the first in Canada to use it. And basically, I know it's going to sound a little crazy, but we put this in through the femoral vein and up across the heart into the pulmonary artery, and we leave it there. And patients get what I call a magic pillow. And when they lie down on the pillow, it automatically transmits the real-time pressures that are in the heart. This device has been studied in a trial called the Champion trial, which I'm showing you here, and showed that by having this real-time information, we were able to see a significant reduction in hospitalizations for heart failure. We've been taking part in the GUIDE HF trial, which is the next trial of this device. We're very excited to have this device available for patients because we think for those patients that are maybe just a little sicker, that this is the type of device that, in addition to Medley, may actually help. So for patients with mild to moderate heart failure, we think more around Medley. And for those patients with moderate to severe heart failure, we think more about Cardiomems and real-time pressure monitoring. So that's where we are. But where are we going? And when I say that I'm introducing the future, I am introducing the future. And from my perspective, I think about our program and so incredibly excited to have recruited Dr. Moyadi back to our program. She spent 2 years at Stanford, as you heard from Shauna. She's completing her master's in translational research. And she's probably not going to talk about it, but she's already won a $280,000 grant to look at a novel monitoring system in transplant patients. But this is the future for the program. This is the future for digital health. And we're tremendously excited to have been able to recruit Yaz. Yaz, I'll hand it over to you.
Thank you, Dr. Ross. So I think a nice place to start is to tell you a bit about our experience with the COVID clinic. And if COVID has any silver lining, it's that it has created an enduring innovation in how we deliver healthcare. And so I suspect post-COVID, and there will be an era that's going to be post-COVID, we're going to see a new normal. And we're going to shift our practice from in-person visits to virtual care. Next slide. So we can move forward. So on March 11th, the WHO declared a pandemic. And our leadership called on us to develop a virtual care clinic. We knew that it had to be virtual because we wanted to avoid unnecessary in-person medical visits. We wanted to avoid unnecessary strain on resources. And we knew that the majority of patients could be triaged in the outpatient setting. Now, for us, from everything that Heather's described so far, the transition to COVID was seamless because we already had a few hundred patients in our remote monitoring, but we could also leverage a technology platform that was being developed for the heart function clinic into the COVID clinic. Next slide. So this is the back of the envelope draft of Imagine the patient journey. And so we wanted to capture the continuum of patients, those who were COVID positive, but also those who had suspected symptoms. And we tried to imagine all of the channels of care that they would be taking. We wanted the information that we gathered to be streamlined, standardized, and we also wanted to provide patient educational material in real time. So really, it took a village to bring this COVID clinic into reality within a few weeks. We relied on the expertise of not just clinicians, but this is where my learning curve was very steep. We relied on technical staff, engineers, hospital support, the integrated care team that brought everybody together. And really, this entire effort was led and coordinated by Dr. Ross. So what we recognized was, given the uncertainties of COVID, we wanted to provide comprehensive care, and we wanted more engagement from subspecialists. We had some engagement from the emergency room physician, but we needed buy-in from all of the subspecialties because COVID had a lot of uncertainties. But we also recognize the importance of providing a holistic approach in the setting of virtual care, which is why nurse practitioners and social workers played such an integral role in this clinic. So as you can see, we were able to recruit close to 50 clinicians, ranging the gamut of various subspecialties. We had 2 nurse practitioners that provided a continuum of care and a social worker who understood the disparities in certain communities. So by numbers, we were quite successful. So as you can see here, up until recently, we've been able to see close to 10,000 patients, resulting in close to 13,000 visits. We've reduced the number of inpatient assessments and averted hospitalizations and emergency room visits. But one of the most important metrics of success is the patient feedback. So, and I do this clinic on a weekly basis, and it's such a gratifying clinic because the patients really appreciate us, but they also recognize that we're providing a service to the community. So when Toronto Public Health was completely overwhelmed with cases a few weeks ago, we were able to reach out to patients before they were and provide a network of support with clinicians, resources, strategies to provide contact tracing. So we were really there for the community. And so what we learned from the COVID clinic is that we were quickly able to create a successful infrastructure to provide virtual care without sacrificing the quality of care. But where we go moving forward is to build on all of the data that we've created from patients beyond medical data and integrate that phone, that wearable data into improving their healthcare. So it's no longer acceptable to say, well, whether we're going to be using digital tools and the information that it captures, but it's now how do we integrate that information and make it a reality? So where we envision going forward into cardiac care is to take all of the wearable data, that's smart watches, smart shirts, smart socks, smart everything, and integrate it into clinical decision tools and provide cutting edge research queries, improve quality of metrics, and grow predictive analytics. So this is where we reach truly personalized medicine. So for that, what that means to me, not yet. So what that means to me, for example, is assuming Dr. Ross is our patient and assuming that she walks about 20,000 steps a day. If there was a dramatic drop in her step count, we need a system to alert clinicians so that we can intervene before she falls off the cliff or before she requires a hospitalization. So we need to be proactive in real time, intervening before the next health encounter. Next slide. So we still depend on the physical exam to give us important information, but we've come a long way from Lennox, rolled piece of paper, or wooden rod to assess the chest. We're now at a point where we can provide patients a device to monitor their heart sounds and ECG from home and make meaningful clinical decisions virtually. We've also gone from gigantic ultrasound machines, which are, state of the art, but only accessible in the hospital, to providing non-specialists, nurses, with a handheld device where we can easily teach them how to take pictures of the heart and again, get very meaningful information. So these tools have made it possible to provide state-of-the-art healthcare in remote communities. So by using Medley, the Echo device, and the POCUS device, we can work with remote communities to provide meaningful care. So currently we have a partnership with the Winnebago Health Authority to provide this type of care. But it's no longer acceptable for us to say, well, Medley is successful at Toronto General, so it must be successful in the North. So what we're doing with this program is understanding the needs of the local community and customizing their digital needs so that we are effective and we're also engaging patients. So as Dr. Ross alluded to in heart failure, prognostics and predicting outcome is very important. The man on your left is undergoing one of the most important tests in heart failure. It's the kind of test that tells you whether the patient is sick enough to require heart transplantation. This is a cardiopulmonary exercise test. But when we think back to our Indigenous communities or our remote communities, these patients don't have access to this state-of-the-art test, and that needs to change. So this is where the Apple Watch and wearables become very important. We may be able to predict when a patient will have an acute heart failure exacerbation by simply wearing a watch. So I'm going to hand it over to Dr. Ross so that she can tell you about some of the cutting edge partnerships that we've made with Apple to make this dream a reality. Thank you.
Yaz. She's understating herself as always. The COVID app and the back of the envelope that you saw was taken from an idea to production in 3 weeks at an academic center. And Joe Duhamel and Yaz, just an incredible amount of work to make that a reality. So you may have heard of the announcement on September the 14th from Sumbul and Apple Cupertino about the partnership with the Petermont Cardiac Center and the Ted Rogers Center for Heart Research. And we are incredibly excited about this opportunity. We have another partnership with Apple Canada as it relates to atrial fibrillation in heart failure. And it was a pretty crazy day when Tim Cook tweeted that he was proud to work with our team. Yaz has punched out that it's had more views than I've ever had. But importantly, what we've been able to do in this partnership with Apple is to develop an app that will allow us to manage and track heart failure patients. So just as Yaz said, really what we're doing, and I can't share too much information with you because I don't want to get into trouble, but the idea is to understand whether or not the information on the watch can be as effective as the traditional testing that we have. Because if it can, then over time, as Yaz has said, if we see trends or changes in a patient's status based on their exercise or other markers on the watch and other sensors on the watch, we may be able to intervene sooner and improve their outcome. So I'll come back to the issue of where I started, which this paradigm of how we manage heart failure, which is in episodes of care. And traditionally, these episodes have been visits every 3 months or every 6 months. With Medley, we've moved to daily episodes of care, 24/7, 365, once daily. With something like the Apple Watch, we can move to the concept of continuous monitoring so that we're not missing something that might happen in between the morning's measurements and the next day. And even more so, it's really important that the type of tools we're looking at are unobtrusive, and so they don't bother the patient when they're actually using them. The other thing that we've done is we've looked at other pieces of data that we may not even have thought were important, but look like they may be quite interesting. And we've done this very major project with weather. So we took 1 million hospital admissions for heart disease over a decade between 2007, 2017. And we were able to get all of the weather features over the same time period. This was just an enormous amount of data. It included things like temperature, precipitation, air pressure, wind, and air quality. And the question we asked was, does weather or clusters of weather associate with heart disease? And you may say, well, why would you do that? For the same reason that you see a pollen index in the summer. Imagine if we were able to find an association between weather and a risk of heart failure hospitalization. It would be one more piece of information that we could help to actually act for patients. And in actual fact, we have found clusters of weather that actually predict some of the variants in heart failure hospitalization, meaning that specific clusters of weather in older people do associate with heart failure risk. So this is really important from our perspective as we think about bringing all these pieces together. And I guess I'd like to make it real for you. So I would ask you today, if there wasn't COVID, but would you get on a plane if you knew that there was only a 72% chance that the plane would land safely? And I'm fairly certain none of you would. This has been one of the biggest challenges, is the ability for us to predict outcomes. And this is where the data becomes so important. We can learn from what Visa has done. So based on artificial intelligence, they use 500 unique attributes to determine in less than 1 millisecond anywhere in the world if a transaction is fraudulent. And they do this 30,000 times per second with a 99.94% accuracy. And what I've said to you is that historically, we're about 72% accurate. So we have to do better. And this is what we're looking at. So software as a medical device, such as Medley, smart clothing, sleep sensors, partnering with University of Toronto to look at lab on a chip where we can get markers in remote environments, adding in machine learning, novel sensors such as Apple has developed, other wearable information, and we do machine learning on all of this information, as well as all of the patient information, the information from the electronic record. Sometimes it's data that we don't even know is important until we start actually pulling it, like the weather. We look at whether or not that information can allow us to triage a patient in terms of their risk. And this is where the virtual environment is, because if we can use it to triage the patient's risk, it'll allow us to intervene importantly early on those patients at the highest risk. And that's what we really want to get to. So to sum, I want every single piece of data there is, all of it. And I want to look at it with my Rogers computational program, which looks at complex biostatistics, and the artificial intelligence team at the PMCC. And I want to be able to get to a place where I can provide the type of decision support for a patient at point of care in real time so that we can intervene and improve the outcome. Not only that, but we want to package this, and we want to package everything that we've learned and provide this to the remote communities and to other communities so that they can learn from what we've learned. We have the most multicultural city on the planet. So we have a low risk of bias in our data because we have such a broad ethnic population. This allows us to create these types of algorithms that can be used broadly. And where we go with this is that each patient starts to teach us as we go in this iterative cycle, and ultimately the value that we bring to the healthcare system is the potential for a learning health system. And that is really the goal. So when I think where I want to be in 2025, I want to be able to tell this individual what his risk is based on all of this information in real time using computational statistics or machine learning to get there. That's the vision that we have here at the Peter Monk Cardiac Center. And I think we can do it, whatever it takes. Thank you.
Thank you, Dr. Ross and Dr. Moyetti. On behalf of all of us, congratulations on your success. In just 7 years, you've achieved remote patient monitoring and virtual care, concepts unfamiliar to many, and have built a program that's truly having a direct impact on patient outcomes. And as we've heard, there's still much more to come. Dr. Ross, going back to your last slide, the one outlining what the future looks like in 2025, what would you say is your biggest challenge that you face to make that vision a reality?
Thank you, Sean. I mean, I think there's a few pieces that are key. One is how we actually get the data. So, for example, with the Apple Watch, there'll be a tremendous amount of data. What we need to understand is what portions or parts or aspects of the data are actually relevant. And that's where the computational statistics or machine learning come in. We have to make sure that we don't have bias in our data. That is a really important piece. So this is ethical artificial intelligence, and we can do some of that by ensuring that our population is broadly representative. So what do I mean by that? If I build a model based on data of 75-year-old white men, that model will really only be good to predict the risk in 75-year-old white men. So importantly, we need to make sure that as much as we're able, that the data is broadly representative. We also need to understand what's happening inside the machine learning. And historically, there's been concerns about black box, or the data comes in and an outcome comes out over here, and we don't really understand how we got from the information or the data here to this recommended outcome. And so some of that is looking inside and understanding what actually went into to make that decision or to make that machine learning algorithm. And so I think these are crucial pieces for us to understand better. The only way we're going to get there is by partnerships with patients, partnerships with industry, partnerships with technology, partnerships with artificial intelligence institutes, partnerships with Vector, the Temerity AI, the Schwartz-Reitzman, as well as Ted Rogers and Peter Monk. This is the way that we're going to get the brains coming together with the actual data to get there. So it's a bit of a long answer, Shauna, but it is important. We really have to be ethically responsible around how we're approaching this. And if we exclude certain populations or what's known as the digital divide, where they don't have access to that, we're not going to be able to represent them or understand how these algorithms or these approaches or interventions might work in them. So these are really important concepts for us, and we have to think about it and remind ourselves so that we do it right.
Great, fantastic. And can I ask a follow-up question? So in this big vision of yours, how do you see the clinical application with other chronic diseases?
That's a great question. Right now, we have with Emily Cito, who is one of the original engineers involved in the Medley algorithm. Medley was her PhD. So she's been working in the area of mental health and working at mental health with heart failure at the moment, because that's a very common for people to have mood issues or even frank depression in heart failure. And we're also looking at, in partnership with the nephrology program, chronic kidney disease. Again, another very common problem associated with heart failure. The other is to look at COPD, keeping the same idea. It wouldn't be the Medley algorithm, but the same idea of an algorithm approach to management. So Joe Cafazzo, who leads the eHealth and Innovation, who's my partner in crime as it relates to these interventions, has a big focus in that area as well.
Wonderful. Thanks so much. I know you've been asked that question once or twice before, so thank you. And Dr. Moyetti, there's a number of hospitals, especially in the wake of the pandemic, that are now accelerating their work in virtual care. And so sort of two questions for you. First, what is the biggest misconception people have about virtual care? It's a very, very used word these days. And the second question is, what is unique about how the Peter Monk Cardiac Center has embraced virtual care compared to other institutions?
Great questions, Shauna. I think the biggest misconception related to virtual care is that it's inadequate to supplement clinical decisions. And so it used to be that we needed to touch the patient, listen to the patient, feel the patient to be able to diagnose. And we're learning through COVID mostly that we can do most of that with along with telemonitoring, and actually maybe even do a better job for a subset of patients. So the misconception is that we can't deliver state-of-the-art healthcare to patients using virtual means. And I think that COVID's completely, canceled that thought, and that's now a myth. With regards to what puts us at an advantage at the Peter Monk Cardiac Center is that we've been ready for this, right? We have, as Heather alluded to, she's been doing Medley for over 10 years. And so remote monitoring is not something new to us. And it came very naturally to transition patients to the platform. And we just do it well because we have a lot of experience. And so, the most important part of our infrastructure is that we're adaptive. And so when big disruptors come, we're able to pivot and actually make great, that's where we actually do great things with innovative thought. And so I think that's what puts us at the forefront of cutting edge work in healthcare, is that we're ready for adaptive change.
Wonderful. And then a follow-up question to that about adaptive change. So you've established this COVID-19 virtual platform, virtual clinic. And as we are now in second wave and moving into the new year, do you think that what you've established will continue to serve COVID-19 patients? Do you think you're going to have to change to adapt anything to make it serve their needs?
Absolutely. So I think we're now seeing record number of cases, and this is where our platform has become that much more useful. It's efficient for clinicians, it's effective for patients, and we're going to start seeing more and more patients through the platform. And we're going to have to triage very carefully who can be followed at home and who needs to come into hospital. And this is the type of tool that we're going to use to be able to make sure that our resources are used appropriately, and that the sickest patients come into hospital, and those who can be looked after safely at home can continue to be we can continue to do so. So I suspect that the platform is going to continue to grow. We're going to use telemonitoring and have Bluetooth devices feeding into the platform so that we can follow patients that much more closely.
Oh, fantastic. Thank you so much. So now I'd like to open up the floor to the questions from our audience. And as a reminder, if you follow the Slido link in your confirmation email for the details, or go to slido.com and type in #BTS, you can submit a question or vote for your favorite. Okay, so now on to the questions. Just closing this. Sorry.
I'll just follow up on Yaz's statement about the other pivot, which is that, and it sort of fits a little bit with the anonymous question at the top. So, the COVID app, incredible. What we have pivoted to is to actually build the same concept to deliver cardiovascular care. So Medley is a patient-facing program. It's a patient-facing management program. It was built with a user-centered design to be specific patient-centered. The COVID app is healthcare practitioner developed. So it's what we use to actually make ourselves more efficient in the delivery of care in a virtual environment. And we have pivoted to create that for cardiovascular follow-up. The hope will be that will launch maybe by the end of the year or the beginning of next year, which will make us more efficient as well in managing patients in the virtual environment. And this is really important. We're learning still some aspects of trying to do things really well virtually, and we want to make ourselves as efficient as possible. So that is one of the other pivots that we're going to be doing with it. And I think, the question about how will it be synchronized through the entire healthcare system is a great one. I know that Ontario Health is extremely interested in virtual care. And I think, again, as Yaz has said, COVID pushed us. We were already moving. It just nudged and pushed us faster because it was a must. And it is the unexpected silver lining of COVID, if I'm allowed to say that, which is that when COVID and vaccines are available and COVID settles down, we're now going to be in a really strong position to continue to provide virtual care, which would limit the number of unnecessary visits for patients, the travel time, carbon emissions, many different ways to measure what that impact might be. So I think the way to think about how it's going to be synchronized through the entire healthcare system involves partnerships with the ministry and with Ontario Health.
Wonderful. Thank you so much. And from Dr. Robin Poole at McGill University, congratulations to your colleagues. We all congratulate you on this extremely important work. How will virtual care support Northern Indigenous communities? Now, you've spoken about the partnership that you have in place right now. So perhaps maybe you can further expand on that and how you think it might support other remote communities, aside and apart from the one that you've established partnership.
Yes?
Sure. So, I think what we're learning through this process, and this is part of our master's thesis, is that we need to customize these digital tools to the local environment. And so, maybe Medley needs to be in Cree, and maybe we need to have specific material so that it's relevant to the specific Indigenous community in Waha or the next community that we engage. But I think, what we're learning is that each community is different and the tools of engagement are going to have to be different as well. And so in the Waha community, they had a failed program through a preventative diabetic system. And so through that program, they learned that the way they engaged patients was just inappropriate. And, you need to have community buy-in. You need to support the community clinically as well. And you just can't go in there with the lens of doing research. And so it needs to be a partnership with that community, and it needs to be tailored to that specific community. So to answer your question, Shauna, I think that each community is going to be different, and we're going to have to tailor our tools to the needs to that specific local environment. And we're starting with one, Waha Moose Factory area, and then we hope that the success of that endeavor will then move on to engaging other communities.
And let me just do a follow-on on that, because I think Yaz is exactly right. We have NIH funding for Medley in Uganda. And when we went to Kampala and then went to some of the rural communities, which the team went to, it was clear that smartphone penetration hadn't really happened, but phones had. And there was a big comfort level in using text-based USSD SMS messaging to transfer money from where the person is working to the home environment. And it's called mobile money. So we looked at that, and Jason Hearn, a remarkable young engineer who worked with us, who's now in medical school, took the Medley algorithm, which is proven, and we put it into a text-based format. And in partnership with Dr. Isaac in Kampala and with Yale, we have revised Medley to be context specific, exactly as Yaz is saying. And so in the Uganda environment, and the clinical trial is just starting in Uganda, and in that environment, it's a text-based system. It still asks for some of the simple questions that Medley asks for, but it's now done through a text-based secure system. And it's very comfortable for the local environment because they're used to texting money, they're used to that system. And although smartphones haven't penetrated, phones are ubiquitous. So that's an example of how to look at things in the local context.
Wonderful, thanks so much. And so next question, why are transplant patients more susceptible to complications with COVID?
Yes, do you want to take that one?
Yeah, I can take a stab. So, when we refer to transplant patients, typically these are patients who are on medications to suppress their immune system. And so what that means is that they don't have the innate responses that somebody who isn't immunosuppressed would have. And by the time they get really sick, they're really farther down on the spectrum. And so it takes a while for them to develop a fever. And for those reasons, they may they may become sicker when they get COVID. And because they don't have the immune response to have, the innate fever, the typical syndrome, it may take longer to diagnose. So I suspect that's why they would become sicker. And, they're not generally more susceptible to COVID in that, they just don't have the innate systems to fight off COVID as the non-immunosuppressed patient would.
Right. Okay. Thank you. And a Medley question. How do you work around the concern for data privacy with Medley? Seems to be a lot of sensitive information on hand, and can our phones be trusted with this?
That's a great question. And I think we're all reminded of the Cambridge Analytica with Facebook. We're reminded of Google and the Ascension project, where it was concern about data and the privacy of data and what might happen. In order to get Health Canada approval, Medley's undergone a tremendous privacy impact assessment. And so it's at the highest level of two-factor authentication and security. We have not had a breach. I would say that the challenge with any data system, as we've seen with hackers and other systems, is that data breach may always be possible, but we put the highest security in compatible with the hospital environment. I take the data privacy piece very seriously. So it is something that we speak about with patients, and that they're aware that the information is on their phone and then transmitted to a safe and secure environment that's housed in the hospital. This is a piece that's also important as we work with our Indigenous partners, recognizing issues around OCAP principles for data. And the idea there would be to have a server locally where the information would stay in order to try to protect the privacy and security of the data. So we have put every measure in place that we can. We are compatible with the hospital requirements. We have passed a privacy impact analysis. But can I guarantee the safety of the data? Unfortunately, I think we've seen that maybe we can't. But to the best standards possible currently, we have done so.
Fantastic. And I know you've been asked this question before too. So have you found that seniors are more reluctant to use this kind of technology?
Not at all.
Yeah.
That's been one of the biggest and pleasant surprises. We have a number of I don't even know how to say. It's not nonagenarians. It's the one after that. So a number of patients in their 90s. I guess that's nonagenarians who are on Medley. Some are using their own phone for it. And sometimes what we do is we provide a system where we provide the phone, the scale and the cuff that we Bluetooth enable before we give them to the patient. They go home with the system and it's all linked. All they have to do is stand on the scale and answer some questions on the phone. From a humorous perspective, I told you about our massive failure with our internet version of Medley. Very early on in one of the first iterations of Medley, we had one of the questions, which was whether or not the implantable defibrillator had fired. And we didn't really answer the question right, and we didn't space the numbers. We were using Blackberries at the time. And so sort of people with pudgy fingers ended up hitting the wrong button. And I used to get alerts all the time that actually weren't real. And I would call the patient because I'd be so worried, but in fact that there was no alert. So this is part of the process of learning and part of the reason why you do these in iterative fashion, because when we originally set it up, we never would have expected all those false alerts just by the size of the finger and the size of the key. So these are things that we've learned. We have tried out extensively in seniors, and it's been no issue for us at all. And in fact, smartphone penetration, the senior market is probably one of the largest growing markets for smartphone applications right now.
Wonderful. So the next one, anonymous, not a question, but a comment. This is incredible technology. Thank you to you and your team for making the patient experience so much more accessible. And then on to the next question. What kind of weather pattern increases cardiac issues?
So this is a really involved project. So we have looked at, from cardiac issues, we've looked at heart attacks or myocardial infarction, and we've looked at heart failure, we've looked at stroke, and we've looked at what's called dissection, or where the artery, the aorta splits and a separate tract of blood goes up the aorta. So we've looked at these 4 different cardiac diseases. What I showed you was the focus on heart failure. And one of the weather patterns that increased the risk of a heart failure hospitalization was low temperature. It's probably intuitive. In low temperatures, the breathing apparatus or bronchi tend to spasm up a bit, and your peripheral resistance tends to go up a little bit in the cold, and it may make the work of the heart harder. And if the heart is weak, that make it more difficult and precipitate heart failure. So there's some logic behind that. But as for all the others, it's very complex, some of the weather patterns and the clusters that we've seen.
Great. Thank you, everyone, for submitting such amazing questions. I hope you have enjoyed today's behind the scene presentation. I hope that has given you a sense of how your generosity fuels so much great work at the hospitals and the impact you're having on people's lives every day. A recording of this presentation will be available on our Foundation YouTube page immediately following this, should you wish to share or view it. We will also be sending around a short survey to our participants. Kindly consider providing your feedback. For those that are interested, we will be hosting the next COVID-19 virtual question and answer on Thursday, December 10th from 5 to 6. The invitation will be emailed to you shortly, and keep an eye out for it. And to Dr. Ross and Moyeti, thank you so much for being part of this. And to all of our listeners, thank you for being here. Stay well, and we hope to see you again soon.